Well, hey, I'm Seth, Field Coordinator for Clinical Care for the Peninsula's EMS Council. Welcome to the 2022 PEMS Protocol Update. As a reminder, these do not go into effect until March 1st, 2022. Let's get started. For the beginning, I have a couple announcements. We're going to then go over some of the administrative updates and procedures, as well as the protocol updates and then some pharmacology updates. One of the announcements is we have a protocol review request form now online. It's on our website. So you use it when you have made recommendations for a change in the scope of practice. For example, maybe you really want to see AEMTs be able to administer fentanyl or morphine for pain management instead of just Toradol. That would be the kind of request you'd put in. That would go to the PPP and then eventually to the MAC. If you find maybe a error or a correction that needs to be done, you can also submit it on this form. Or if you see maybe a new treatment or intervention that you would like the Policies, Procedures, and Protocol Committee to review, you could also use the form for that. Regarding our PEMS medication box exchange, Virginia is one of the few states that still allows EMS to exchange drug boxes at the hospital. So please be sure you use those forms in the box every time. This helps ensure compliance with regulations, as well as helps protect the integrity of our program and ensures the future of this capability. There's also a protocol format survey on the PEMS website. It'll be open until April 1st. We're asking EMS providers, OMDs, anyone interested to fill out that survey. The PPP committee has been looking at the format and wants to get input from the field to see if there's a better way or an easier way, or if they like the way things are now. So please be sure to go to our website before April 1st and complete that survey. Another reminder, when you are transporting a patient with a stroke or potential stroke, in addition to acquiring the RACE score, please remember to both obtain the last known well and contact information of family members. That's essential so they can get consent for a treatment or procedure if the patient cannot express that. And they also give the family members updates of what's going on. There were a few administrative updates to the protocols. For one, under the hypoglycemia and hyperglycemia protocol, the units regarding BGL were corrected. Drowning and diving protocols, they're actually combined into one protocol because they were both exactly the same. And then under the transportation destination determination, there was still a lingering reference to Ativan, and that was removed because Ativan was removed from the medication box in a previous year. As you begin to look through the procedure pages, you'll actually notice that they are now all in a format similar to the protocol format. We believe this will make it easier for providers to use and to follow when they have to use them in the field. There were several new procedures added to the protocols this year. For example, adult CPR. And that's because currently it just says refer to AHA guidelines. So if you're in the middle of a cardiac arrest, work in a cardiac arrest, I should say, and need to go through those procedures, now you can just flip to the adult CPR or the pediatric CPR. Our pediatric care committee put that together also. The airway management protocols come back, or procedures come back, and it includes foreign body airway obstruction, which is currently under asthma, COPD, and respiratory distress. So airway management is now back, and it includes foreign body airway obstruction. The VAD procedure was replaced by the medical devices and pumps. This is actually a really good resource. It has things on even working cardiac arrest with some of these medical devices. So be sure to look at that. Medication administration was added. It's just a good review of how to administer medications via different routes. Spinal motion restriction is the new reference to backboarding, basically, or C collars. We're no longer calling it spinal immobilization since we really can't completely immobilize. But you'll see the spinal motion restriction. There also has criteria, which will be the way that we work our clearance. The surgical airway procedure really just combined needle and surgical crikes into one procedure. Transcutaneous pacing replaced external cardiac pacing, just kind of updated the wording as well as the process. Central venous catheter access procedure was removed because we really don't need it and don't use it since AEMT and above can use IO if they cannot get IV access. So during the PEMS Pediatric Care Committee, we were discussing medical control. And both the CHKD and VCU Children's Hospital physicians said, please use us if you need for med control. Even if you're not transporting to us, but you need a specialist or specialty or some specific guidance, please call. You'll find in the PEMS Protocol app that there are now hyperlinks, so you'll find the phone number. And if you click on that, it should pull up your phone app as long as you got cell phone reception and allow you to make the phone call. There's several of those links all throughout the procedures and protocols, including the core and here phone numbers. The PEMS protocol, or sorry, the PEMS Pediatric Care Committee went through all of the pediatric protocols and updated them. Some hadn't been touched for quite a few years. Um, The only change here for the age-based vital signs was there's a definition of hypotension based on age. So that's going to be a very good resource. Within the PEA protocol, calcium chloride and sodium bicarb for renal dialysis, crush injuries, or suspected hyperkalemia, pediatric patients was added. And then with burns, and you'll see this throughout, fluid administration is really only recommended for a total body substance area of about 20%. And we're talking second and third degrees, really not a whole bunch of first degree like sunburn. And also signs of poor perfusion. With the VFib pulses VTAC, AEMT can administer fluids. We've added calcium chloride and sodium bicarb for persistent VFib or VTAC in renal dialysis patients with suspected calcium channel blocker overdose or suspected hyperkalemia. You'll see also there's been a less of an emphasis on advanced airways and more of an emphasis on BLS airway management. It's usually referred to as using the least invasive means necessary, and that's through the peds, adults, trauma. They really found that endotracheal intubation is not always the gold standard. And a matter of fact, sometimes it actually makes it worse on the patient. That doesn't mean if your patient needs to be intubated, don't intubate them. It just means if they don't need it, don't do it. So consider the least invasive means necessary when managing your patient's airway. For electrical injuries, again, manage the airway with the least invasive means necessary. They've added the estimating the total body substance area for burns, and also IV administration has some more guidance. You can also contact med control. Again, you can contact VCU, CHKD, or your local hospital. They also recommend, or actually added, obtaining a 12 lead, which makes sense since it's an electrical injury and can cause some cardiac compromise. So for pain control, they've added or kind of redid the fentanyl. You've got 1 microgram per kilogram IN or IM, or you can put 0.5 micrograms per kilogram IV IO over 2 minutes. You can repeat every 10 to 15 minutes with a max dose of 100 micrograms. And with morphine, the max dose is reduced to 2.5, but you can repeat every 10 to 15 minutes to a total of 10 micrograms, 10 milligrams. As I mentioned before, with this respiratory distress and asthma, they moved the foreign body obstruction airway over to the airway management protocol. AEMT for asthma can administer solumedrol and mag sulfate, and intermediates no longer have to contact med control. For bronchiolitis, they've removed neb saline, and they've also separated bronchiolitis from croup and stridor. With those, you might want to consider nebbing epinephrine 1 to 1,000, about 3 mils. And they've also removed the hyperventilation syndrome from this respiratory distress protocol. For seizures, Midazolam and Versed, they kind of gave a weight range just for faster and easier administration. The initial administration should be IN or IM. And then if the seizure persists, you can give another second dose after 5 minutes. That can be IN or IM, or IV or IO, but it's at a lower dosage. If the seizure continues after the second dose, definitely contact med control. With trauma, as I mentioned, the spinal immobilization has been changed to spinal motion restriction, and we've added the manage the airway by the least invasive means possible. And there's also a modified pediatric Glasgow Coma Scale reference in this section. For VTAC with a pulse, they recommend anytime, of course, but in this protocol, EMT should obtain and transmit an ECG. And the protocol is actually laid out very well now. Differentiates between stable and unstable VTAC with a pulse and how to manage that patient. Within the pharmacology section, you'll find some new references. Now, these are references pages only to help with training and awareness of the medication used with RSI. You will not find these medications in the standard yellow PEMS medication box. Also within the pharmacology updates, there's been just a lot more simplification. The dextrose, all those pages have been combined into one. The epinephrine, same thing, has all been put onto one page, and so has the Zofran. So you'll see all these have been combined to one page per medication. As always, a representative from the agency can request advanced distribution of the 2022 protocols in preparation for printing, if you still choose to print, or for training. They just need to email me at scraig@vaems.org. Again, they cannot be released into the field until March 1st, 2022, and that's when they actually go into effect. Thank you for your time. As I always say, if you don't like how things are going, be the change. There's a lot of ways to help and get involved within the Peninsula EMS region. Continue to do what you do, stay safe, and until next time.